Welcome back to Therapeutics. We'll speak a bit about genitourinary conditions, and we'll wrap it up with sexually transmitted infections. For all of this content, we'll give you pretty much just the framework of therapeutics, and this will be augmented in the clinical medicine components of your curriculum.
Let's spend some time now looking at the 2021 updated guidelines from the CDC for sexually transmitted infections. We'll start first with herpes simplex, classically divided into type 1 and type 2. Type 1, historically, we always thought of limited to oral or lesions that would be a one-time only kind of phenomenon. And HSV2, classically genital herpes, usually in the genital area with recurrent outbreaks. There's some crossover here. It might be related to the fact that folks who are sexually active are engaging maybe in more oral sexual activity, which could then cause some lesions that were historically limited to one area in the other area. But as such, I'd encourage you to look through what in ClinMed you've discussed in the diagnosis and management of herpes, and then let's look at the guidelines from the CDC. There are a number of slides here, but first of all, let's talk about management for someone's first clinical episode of genital herpes. The options here are acyclovir, famciclovir, or valacyclovir. Most clinicians these days will go with valacyclovir in that it is easy to dose. It is a 2-time-a-day regimen. It is relatively inexpensive. It has viral suppression for the entire dosing interval, as opposed to acyclovir, which classically should be given, if given orally, up to 5 times a day, and is really hard for adherence. For folks who have need of suppression of recurrent herpes, regimens listed here also, and again, valacyclovir is a once-a-day regimen, is usually probably by most clinicians preferred. The advantage of suppression really is twofold. One is to really improve a patient's individual response to herpes and have fewer outbreaks of herpes. And secondly, to greatly reduce the ability of that person to inadvertently transmit herpes to a partner. There are also other recommendations for episodic treatment for recurrent herpes guidelines here. Again, valacyclovir is usually bumped up maybe to a higher dose for a 5-day period, and then resuming the maybe a lower dose for recurrent maintenance. And then more guidelines for patients who have HIV. Again, dosing regimens listed here. What you'll see, though, for folks who are immunosuppressed, particularly with HIV, is that, among other things, the valacyclovir dose is twice a day. It's a higher dose than it is in persons who don't have HIV. In addition, recommendations for genital herpes among pregnant women. Again, valacyclovir is a recommended regimen, again, here as well. The last thing to think about when we talk about herpes, and this would not be a common phenomenon, but you want to have it in your radar, is a person who has herpes encephalitis, whether or not someone has a history of genital herpes or herpes HS1 type. When you worry about a central nervous system involvement, we will use intravenous acyclovir, typically at 10 milligram per kilogram every 8 hours, although that needs to be renally adjusted. Moving on to other sexually transmitted infections, one listed here over the last decade or so has become more concerning for us is granuloma inguinale. And this is a genital ulcerative disease. It is not commonly seen in the United States, but may be seen more over the next decade or two, and it is still seen. The regimens typically here are azithromycin or doxycycline, the very same regimens that we will use with chlamydia, for example. For lymphogranuloma venereum, or trichomoniasis. Again, a situation here, doxycycline for non-pregnant or childbearing women is recommended, and azithro would be the choice, particularly for a woman who is of childbearing age who could be pregnant, as doxycycline would not be recommended in that individual. The guidelines for syphilis have not primarily changed all that much, but the role of monitoring for patients with sexually transmitted for syphilis has really gone up in the last decade. And so we really are concerned with syphilis that never really was eradicated, but wasn't as common as we commonly see at this point in time. For primary syphilis, we typically classically look at primary syphilis is after early exposure, and secondary and latent syphilis 4 to 10 weeks after exposure with the characteristic palm and sole lesions. The treatments per the CDC for primary and secondary syphilis consist of long-acting IM injection of penicillin G, typically as a single dose, or dosing listed in infants and children here as well. And in infants and children, you have to think of what is the cause of that syphilis. So in newborns, you may think it might be an issue of in a vaginal delivery exposure. And in children or older infants, you have to be thinking about sexual assault and all of the things that sort of go into that decision-making process. For latent and tertiary syphilis, much more complicated. Our regimens are typically the same drugs, but with a more aggressive dosing regimen plan. Here are the CDC dosing guidelines for latent syphilis, depending on whether it's earlier or late. The dose of penicillin G, either as a single dose or in later latent syphilis, more aggressive dosing. And then in tertiary syphilis, we're typically looking at even more aggressive dosing of penicillin. You typically would probably get an ID consult in these cases, and these are individuals who may actually require careful monitoring to confirm that they don't sort of evolve into neurosyphilis. Neurosyphilis, where CNS infection is an issue, again, is aggressive doses of penicillins. So the neurosyphilis or ocular syphilis or otosyphilis in adults is given pretty much intravenous penicillin G, high dose. You could consider IM dosing with probenecid as listed here as well, but that's not ideal. And I think when you get in the realm of this situation, you're not only notifying the ID service, but there might be some public health reporting for any case of syphilis as well. Finally, some other issues you think of are folks who have syphilis who also have HIV or otherwise immunosuppressed. Again, the dosing is similar as we see in earlier slides, but typically with neurosyphilis, we are getting a more aggressive in our dosing as well. And of the last steps in syphilis management regimens in pregnancy, we typically recommend the typical penicillin regimens as well. Penicillins, beta-lactams considered relatively safe in pregnancy. Other issues to consider in syphilis management are congenital syphilis and regimens seen in other populations as well. In guidelines, again, all penicillin. And then recommendations for other issues where you're making considerations for infants and children and treating, again, being concerned for any sexually transmitted infection in a child, you would perhaps flag the potential for sexual abuse. The other question with syphilis comes into play is that really the treatment of choice is penicillin. So if you have a patient who has a penicillin allergy, there really is not a recommended alternative regimen classically for syphilis, and I think in that patient might very well be a candidate for penicillin desensitization. At the very least, you're probably in a pen-allergic patient going to touch base with either the public health department or the infectious disease service about how to manage that syphilis in a patient who has a pen allergy, and whether or not they'd be a candidate for a penicillin desensitization protocol prior to administering the appropriate doses of penicillin. Other sexually transmitted infections, non-gonococcal urethritis, a very common scenario. We classically will recommend doxycycline for 7 days or azithro. The advantage of azithro is A, in women who are childbearing age or pregnant. That's the drug of choice as opposed to doxycycline. The other advantage of azithro, even if it is secondary for because of resistance patterns, is easier in that it's a single dose, as opposed to sometimes if you've got someone who is non-adherent, a 7-day course of doxycycline is difficult. So doxy, even though it is a first-line recommended plan, would not be first-line in a woman of childbearing age who could be pregnant, and is not first-line in a patient for whom you are not confident that they are going to complete a 7-day course of therapy. Cervicitis management, here we're looking at doxycycline again or azithromycin as our alternative for the same sort of conditions. The same is true, and the same thinking goes true for chlamydia. And chlamydia in women who are pregnant, the alternatives are azithro, maybe amoxicillin. I think amoxicillin is a more distant recommendation in these guidelines. Also, other recommendations among neonates and infants, and the considerations again for sexually transmitted infections in this population. And again, the other considerations are listed here, again, for sexual abuse as a consideration with any of these infections in among infants and children. Gonorrhea treatment. Gonorrhea has seen more infections and resistance in the last decade or so, and so we're really getting concerned about how we manage gonorrhea. The guidelines recommend for gonorrhea ceftriaxone, and typically because you're concerned about concurrent chlamydia, you would look at either doxycycline or azithro as being added to ceftriaxone. So the ceftriaxone for the gonorrhea, and either the doxycycline or the azithro for the coverage of chlamydia unless you have ruled out chlamydia. You'll see on this guideline as an alternative to ceftriaxone is also cefixime, high-dose oral cephalosporin. This is usually not recommended as a first line because there's been some resistance to oral cephalosporin therapy for gonorrhea, and so it is not routinely used orally. If you had some reason where you couldn't use it, then you're looking at cefixime in combination with gentamicin, which is not really ideal. In addition, other recommendations listed here for oral pharyngeal complications with gonorrhea, where the ceftriaxone dose is anywhere between 500 milligrams to a gram. For patients who are larger, a gram is often recommended, and that's also true for conjunctivitis. Again, more if patients have gonorrhea with arthritis symptoms. Again, we're looking at more aggressive dosing of ceftriaxone at higher doses, even given IV, for up to 7 days with concurrent doxycycline. And for endocarditis or meningitis, we're looking at, again, aggressive ceftriaxone dosing, probably in the range of 2 grams every 24 to even 2 grams every 12 hours, plus if you have an excluded chlamydia, doxycycline, and or perhaps azithro. Other issues or recommendations here in newborns. They typically will recommend not giving ceftriaxone in a newborn, but would be given if they were over a month of age, or if you are confirming that there's not an issue with bilirubin clearance because of the concern for risk for kernicterus. So cefotaxime might be a better choice in that cohort. Similarly, in this population, again, neonatal gonorrheal infection guidelines are listed here with a caution about ceftriaxone in premature or under a month of age patients, where we are concerned about bilirubin levels and bilirubin clearance. Finally, the last slide about dosing with gonorrhea is regarding a regimen for uncomplicated gonococcal vulvovaginitis or cervicitis in children weighing more than 45 kilograms or in arthritis or bacteremia in children as well. Again, ceftriaxone across the board pretty much. Next is Mycoplasma genitalium, which can be either symptomatic or asymptomatic for urethritis among men, and is among women. It is a high risk among, as is gonorrhea, for pelvic inflammatory disease. So we want to be clear about managing it appropriately. The regimens typically are doxycycline again, but again for women of childbearing age, you want to be sort of clear about that. If it's a macrolide sensitive, they're also going to get azithro. If it's macrolide resistant, they'd be candidates for moxifloxacin. These regimens, though, would not be ideal. Both doxy and moxy are not considered appropriate for women who could be pregnant. So you want to rule out pregnancy and manage appropriately. For bacterial vaginosis, we're going to look at classically metronidazole or perhaps clindamycin topically. There's some other alternative regimens at the bottom, but each of those are quite infrequently used. Really, metronidazole is the agent of choice, either orally or as a gel. Trichomoniasis, again, regimens here, metronidazole is probably the drugs of choice here. For vulvovaginal candidiasis with Candida albicans, there's lots of sort of treatment regimens that are often listed here, which may or may not be sexually transmitted. The issues here are identified by classifying them per the CDC. You can sort of look at whether or not they're considered uncomplicated or complicated. And then the regimens, there are multiple regimens, but what many clinicians these days do classically will go with a single dose of oral fluconazole. The remaining treatments are really possibilities, but they have fallen somewhat out of favor with a lot of patients because they're complicated to administer and patients may or may not like them. Probably the only one that has a little better adherence to it is a single dose meconazole vaginal suppository as a single dose, but that may not be quite as effective as oral fluconazole is. We also alluded earlier to pelvic inflammatory disease. We worry about this particularly with gonorrhea or trichomoniasis, but we can see it with other pathogens as well. Our management for PID typically looks at multi-drug regimen, classically a third-generation cephalosporin, or maybe the second-generation cephalosporin, cefotetan or cefoxitin, with the combination of doxycycline and making sure you've got anaerobe coverage if you use ceftriaxone with metronidazole. There are alternate regimens as well for PID. There's amsulbactam, which has reasonable anaerobe coverage, but with that we will look at doxycycline or Clinda or Clinda plus Gent as an option as well. There are other recommendations for IM and oral regimens for PID when it's either step down post-IM, post-IV therapy, or if it's early in the course where a patient has a milder symptomatology and is not a candidate for hospital admission. But these would be sort of second line if a patient really needs IV PID therapy. Some of the last things we're going to sort of mop up with in the sexually transmitted infection block is epididymitis, which is sort of common. We'll see this as trichomoniasis or gonorrhea or Mycobacterium genitalium as a risk pathogen. Sometimes you'll also see E. coli as a pathogen here as well. The treatment regimens typically include ceftriaxone plus doxy, or there might be a combination of ceftriaxone plus levofloxacin. And so that's not uncommon to see either of those regimens typically used. For anogenital warts, which are quite common, typically there are lots of different HPV types and subtypes. We also worry about potential cancer risks with such patients, and so you're hoping that someone who has had HPV vaccination might have a lower risk for these complications. The management acutely of a wart include a lot of topically applied regimens and or surgical removal or some type of a cryotherapy process. There are other sort of for vaginal warts similarly as for urethral medius warts, but those are typically done in an office-based setting or practice. And finally, recommendations similar depending on where the warts are located and how the procedure is done. For acute proctitis, we see the classic recommendation is ceftriaxone to cover for gonorrhea and doxycycline as well. And that's a typical, very common regimen for acute proctitis, and we typically look for a 7-day regimen. Typically for chronic proctitis, we typically will look at a long-term course of either a fluoroquinolone or Bactrim therapy. For lice therapy, we talk about this elsewhere in the program, but classically or elsewhere in the curriculum, but permethrin is considered the drugs of choice. Those are available over the counter, and many times patients will sort of do that on their own. For resistant cases, might be malathion or ivermectin, but those are really considered when you have refractory permethrin type lice. Scabies, like lice, same recommendations, except scabies requires more aggressive management and might require more aggressive treatment with either ivermectin or with lindane, although we avoid lindane in infants and children because of neurotoxicity risk. And then finally, sexual assault. You want to be thinking of all of the things involved in sexual assault, the chain of custody of evidence, getting the appropriate workup. I'd encourage you when you do your emergency room rotation to spend some time with the team who manages sexual assault, looking at how that's managed, who's contacted, how the chain of evidence is done, how the counseling happens. And for the regimen therapy of protection, it's typically ceftriaxone plus doxy plus metronidazole. And you also want to kind of work up what other risks the patient may have had as a risk strategy. Would they be candidates also, for example, for post-exposure prophylaxis for HIV? Is there something else, that they need to keep an eye on related to infection exposure during the assault, as well as all of course, the psychological, emotional, post-traumatic stress issues that are appropriate to do. Okay, very good.
So in sexually transmitted infection, men's health, and GU